Bismillahirrahmanirrahim. Ramzan is like the rain, it nourishes the seeds of the good deeds. Today, the topic of presentation is on measles under the kind supervision of Professor Dr. Saira. The learning outlines of today's presentation is epidemiology, cause, signs, symptoms, diagnosis, treatment, complications, and prevention of measles, and the recent advances, and at the last are the MCPS. Now, measles is a highly contagious, serious disease caused by a virus. Before the introduction of measles vaccine in 1963 and widespread vaccination, more epidemics occurred approximately every 2 to 3 years, and measles caused an estimated 2.6 million deaths every year. In the background, in the decade before the live measles vaccines were licensed in 1963, in USA, 5,49,000 measles cases occur annually and 495 measles deaths annually. And 3 to 4 million people were infected with measles annually. Most cases were not reported. Of the reported cases, 48,000 people were hospitalized from measles. 1,000 people developed chronic disability from acute encephalitis caused by measles annually. Now, measles elimination. Now, what is measles elimination? It is defined as the absence of endemic measles virus transmission in a defined geographic area, such as a region or a country, for 12 months or longer in the presence of a well-performing surveillance system. In year 2000, measles were declared eliminated from the United States. However, measles cases and outbreaks still occur every year in the states because measles is still commonly transmitted in many parts of the world, including the countries in Europe, Middle East, Asia, America, and Africa. Now the trends in measles outbreak in USA is elimination. Measles cases were reported after the year 2000 as low as 37 in 2004 and as high as 1282 in the year 2019. The majority of cases in the United States have been among people who are not vaccinated against measles. Measles cases occur as a result of importations by people who were infected while in other countries and from the subsequent transmission that may occur from those importations. Measles is most likely to be spread and cause outbreak in communities where groups of people are unvaccinated. Now the problem statement of measles. More than 140,000 people died from measles in 2018, mostly children under the age of 5 years. Measles is endemic in virtually all the parts of the world. It tends to occur in epidemics when the proportion of susceptible children reaches 40%. When introduced into a virgin community, more than 90% of that community become infected. The primary reason for high childhood morbidity and mortality is failure to deliver at least a single dose of vaccine. Now the epidemiological determinants of measles. The agent is the RNA paramyxovirus. The host factor includes the age is most commonly between the 6 months and 3 years of age in developing countries, and in developed countries it is over the age of 5 years. And the environmental factors include the overcrowding. Now in detail, the agent factors. It is caused by RNA paramyxovirus. It is the only one serotype of the RNA paramyxovirus known, and it cannot survive outside the human body for any length of time. The only source of infection is the case of measles. Carriers are known to occur. The infective material is the secretions of the nose, throat, and respiratory tract of a case of measles during the prodromal period and the early stages of the rash. Communicability. Measles is highly infectious during the prodromal period, and at the time of eruption, communicability declines rapidly after the appearance of rash. Period of communicability is approximately 4 days before and 4 days after the appearance of rash. Now the secondary attack rate. There is only one known antigenic type of measles virus. Infection once confers lifelong immunity. Now the host factors. Age affects virtually everyone in infancy or childhood, most commonly between the ages of 6 months and 3 years of age in developing countries where environmental conditions are generally poor, and older children usually over 5 years in developed countries. In gender, it is the incidence is equal in both the sexes. Nutrition. Measles tend to be very severe in malnourished child, carrying a mortality up to 400 times higher than in well-nourished children having measles. Immunity. No age is immune if there was no previous immunity. One attack of measles generally confers lifelong immunity. Second attacks are rare. Infants are protected by maternal antibodies up to 6 months of age. In some, maternal immunity may persist beyond 9 months. Immunity after vaccination is quite solid and long-lasting. Now the environmental factors. Given a chance, the virus can spread in any season. In tropical zones, most cases of measles occur during the dry season. In temperate climates, like in Pakistan, measles is a winter disease, probably because people crowd together indoors. Epidemics of measles more common in Pakistan during the winter and early spring in the months of January to April. Population density and movement do affect epidemicity. In general, the less favorable the prevailing socio-economic conditions, the lower the average age at which children are attacked. Now the transmission. The virus spreads directly from person to person, mainly by droplet infection and droplet nuclei. And the period of infectivity is from 4 days before the onset of rash until the 4 days thereafter. The portal of entry is respiratory tract. Infection through conjunctiva is also considered. Recipients of measles vaccine are not contagious to others. Know the incubation period. On day 1, when a person is exposed to a virus, on 10th day, the onset of fever, there is the onset of fever. So the incubation period for the onset of incubation period of measles for the onset of fever is 10 days, while for the onset of rash that appears on the 14 days is 14 days. When measles infection is artificially induced by passing the respiratory tract, as with injection of live measles vaccine, the incubation period is somewhat shortened, averaging 7 days. Now the clinical manifestation. Uh, the clinical manifestation include the 3 stages that are the prodromal that lasts from 10 to 14 days and the eruptive phase that lasts for 14 to more than 18 days and the post-middle stage that starts after the 18 days. Now the prodromal stage. It begins 10 days after the infection and lasts until the day 14. In this, cough, coryza, and conjunctivitis occur that are the 3 C's of the measles. It is characterized by fever, coryza, and with sneezing and nasal discharge, cough, redness of the eyes, lacrimation, and often photophobia. There may be vomiting or diarrhea. The pathogenomic of the measles is the caplonic spores. A day or two before the appearance of the rash, caplonic spores like table salt crystals appear on the buccal mucosa opposite the first and second lower molar toes, as shown in this picture. These white crystals, white rashes are the caplonic spores inside the cheek. These are the small bluish spores on the red base, smaller than a head of a pin. Their presence is the pathogenomic of measles. Now the eruptive phase. This phase is characterized by a typical dusky red macular or maculopapular. Macule are the not raised lesions. These are only the pigmentary lesions, while the papules are the raised lesions. Macular papular rash, which begins behind the ears and spreads rapidly in a few hours over the face and neck and extends down the body, taking 2 to 3 days to progress to the lower extremities. The rash may remain discrete, but often it becomes confluent and blotchy. Confluence means many rashes become attached together and form a one large rash. In the absence of complications, the lesions and fever disappear in another 3 to 4 days, signaling the end of the disease. The rash fades in the same order of appearance, leaving the brownish discoloration, which may persist for 2 months or more. Now the post-measles stage. The child will have lost weight and will remain weak for a number of days. There may be failure to recover and a gradual deterioration into chronic illness due to increased susceptibility to other bacterial and viral infections. Nutrition and metabolic effects and tissue destructive effects of the virus. There may be growth retardation and diarrhea, cankerem oris, pyogenic infection, candidosis, reactivation of pulmonary tuberculosis, and others. Now, this is the graphical representation of the various signs and symptoms of the measles. On day 0, there is the exposure to the virus. This is the incubation period from day 1 to day 10. And on day 10, fever starts, which lasts for about 18 days. And after the fever, on 11 to 12 days, the 3 C's may appear. And the rash appears mostly on the day 14. And the copulae spores that also appears on the day 12 or 13. Now the diagnosis of measles. Diagnosis is based on typical rash and colloid spots seen in a oral mucosa. The diagnosis would normally be incorrect in any febrile exanthem in which red eyes and cough are absent. In developed countries where measles is uncommon, specific IgM antibodies are being used for diagnosis. Now the complications. There are numerous complications like diarrhea, pneumonia, otitis media, and others. In pneumonia, it is the most common life-threatening complication, and it occurs in less than 10% of cases in developed countries. 20 to 80% of cases in developed countries, pulmonary complications account for 90% of all deaths due to measles. Most cases are due to virus itself rather than the bacteria. Otitis media complications contribute to 5 to 10% of cases. No, this is another life-threatening complication of measles, that is the subacute sclerosing panencephalitis. It is a rare complication which develops many years after the initial measles infection. It is characterized by progressive mental deterioration leading to paralysis, involuntary movements, muscle rigidity, and coma, probably due to persistence of virus in the brain. The diagnosis of subacute sclerosing panencephalitis may be made early by the demonstration of high level of measles complement-fixing antibodies in the cerebrospinal fluid and serum. The frequency of SSPE is about 1 into 300,000 cases of natural measles. It is usually fatal within 1 to 2 years after onset. The mortality rate in encephalitis associated with measles is about 10 to 20%. The majority of survivors have neurological sequelae. Now the encephalitis. It is another serious complication. It occurs in about 1 in 1,000 cases. The cause is unknown. Measles vaccination definitely constitutes a protection against the neurological and other complications by preventing natural measles from occurring. Now the measles during pregnancy. Measles is not known to cause congenital abnormalities of the fetus. However, it is associated with spontaneous abortion and premature delivery. Measles in offspring of mothers with measles ranges from mild to severe. Therefore, it is recommended that infants born to such mothers be passively immunized with immunoglobulins at birth. No people at high risk for complications. These include infants and children less than 5 years of age, adults whose age is uh, more than 20 years, pregnant women, people with compromised immune systems such as from leukemia or HIV infections. Know the treatment of measles. There is no specific antiviral therapy for measles. Medical care is supportive and to help relieve symptoms and address complications such as bacterial infections. Supportive care that ensures good nutrition, adequate fluid intake, and treatment of dehydration with WHO recommended oral dehydration solution. Measles lead to deficiency of vitamin A. So in measles, we recommend vitamin A derivative. Severe measles cases among children such as those who are hospitalized should be treated with vitamin A to prevent keratomelia and blindness. Vitamin A should be administered immediately on diagnosis and repeated the next day. The recommended age-specific daily doses are 50,000 international units for infants younger than 6 months of age, 100,000 international units for infants 6 to 11 months of age, and 200,000 international units for children 12 months of age and older. For the prevention, the following guidelines are important in combating measles: achieving an immunization rate of over 95% and ongoing immunization against measles through successive generations of children. No measles vaccine. Only live attenuated vaccines are recommended for use. They are both safe and effective and may be used interchangeably within immunization programs. Person-to-person transmission of measles vaccine strains has never been documented. Age. The principal problem of measles immunization is timing. Immunization before the age of 9 months runs the risk of vaccine being rendered ineffective by the natural antibodies acquired through the mother. Immunization later than 9 months means that a significant portion of children will contract measles in the interval between wearing of natural protection and the introduction of the vaccine. The most effective compromise is in immunization as close to the age of 9 months as possible. The WHO expanded program on immunization recommends immunization at 9 months of age. The age can be lowered to 6 months if there is measles outbreak in community. Not the administration. The reconstituted vaccine is generally injected subcutaneously, but it is also effective when administered intramuscularly. Immune responses. Measles vaccine induces both humoral and cellular immune response comparable to those following natural infection, although antibody titers are usually lower. Also lower average concentration of maternal antibodies are found in infants born to vaccinated mothers when compared with natural infected mothers. Following vaccination, transient measles-specific immunoglobulins (IgM) antibodies appear in blood and IgA antibodies appear in mucosal secretion. IgG antibodies are persist in blood for 3 years. Vaccination also induces measles virus-specific CD4 plus and CD8 plus T lymphocytes. Now the immunity. Immunity develops 11 to 12 days after vaccination and appears to be of long duration, probably for life. One dose of vaccine given at 11 to 12 months of age appears to give 99% protection. Infants vaccinated at the age of 9 months show seroconversion of about 90%. Know the context. Susceptible contacts over the age of 9 to 12 months may be protected against measles with measles vaccine provided that this is given within 3 days of exposure. This is because the incubation period of measles induced by the vaccine is about 7 days compared with the 10 days for the naturally acquired measles. Know the adverse effects of vaccine. The most common and severe adverse effect is toxic shock syndrome. It occurs when measles vaccine is contaminated or the same vial is used for more than one session on the same day or the next day. The vaccine should not be used after 4 hours of opening the vial. Toxic shock syndrome is totally preventable and reflects poor quality of immunization services. The symptoms of toxic shock syndrome are typical that are severe watery diarrhea, vomiting, and high fever are reported within few hours of measles vaccination. There are usually a cluster of cases as all infants vaccinated from contaminated vial will be affected. This may cause death within 48 hours. The case fatality rates are high. Now the second dose of measles vaccines. Second dose may be added to routine immunization schedule in countries that have achieved 80% coverage of the first dose of the vaccine at the national level for 3 consecutive years. In general, countries that do not meet this criteria should prioritize improving administering the uh, first dose of measles vaccine coverage and conducting high quality flow up in uh, subnational immunization drives rather than adding the second dose to their routine schedule. Now, this is the routine immunization schedule in Pakistan. In this, and the measles vaccine is given along with rubella at the 9 months of age, and the second dose is given at 15 months of age. Now, the immunoglobulins. Measles may be prevented by administration of human immunoglobulins early in the incubation period. The dose recommended by WHO is 0.25 ml per kg of the body weight. It should be given within 3 to 4 days of exposure. The person passively immunized should be given live measles vaccine 8 to 12 weeks later. The need for immunoglobulin is no much reduced because of availability of an effective live attenuated vaccine. Now the eradication of measles. It is believed that measles, like smallpox, is amenable to eradications. Measles immunization has in its favor the fact that only one dose is needed and that a measles vaccine has no been developed which is more heat stable. It requires achieving an immunization coverage of at least 96% of its children under 1 year of age and that the accumulation in the immunity gap prevented. Know the outbreak control measures. The following control measures have been recommended. Isolation for 7 days after the onset of rash. Immunization of contacts within 2 days of exposure. If vaccine is contraindicated, immunoglobulin should be given within 3 to 4 days of exposure. Prompt immunization at the beginning of an epidemic is essential to limit the spread. Now the WHO response. In 2012, the Health Assembly endorsed the Global Vaccine Action Plan with the objective of eliminating measles in 4 WHO regions by 2015 and in 5 regions by 2020. By 2018, the global push to improve vaccine coverage resulted in 73% reduction in deaths during 2002 to 2018. With support from the Measles and Rubella Initiative and Gavi, the Vaccine Alliance, measles vaccination prevented an estimated 23.2 million deaths. Most of the deaths averted were in African region and in countries supported by the Gavi Alliance. Now, the Measles and Rubella Initiative that's launched in 2001. It is a global partnership led by the American Red Cross, United Nations Foundation, CDC, UNICEF, and WHO. This initiative is committed to ensuring that no child dies from measles or is born with congenital rubella syndrome. The initiative helps countries to plan, found, and measure efforts to stop measles and rubella for good. In 2010, the World Health Assembly established three milestones towards future eradication of measles to be achieved by 2015. That includes increased routine coverage with first days of measles containing vaccine by more than 90% nationally and more than 80% in every district, and reduce estimated measles mortality by more than 95% from the 2000 estimate, and reduce and maintain annual measles incidence to less than 5 cases per million. But without sustained attention, hard-fought gains can easily be lost. Where children are unvaccinated, outbreaks occur because of low coverage nationally or in pockets. Multiple regions were hit with large measles outbreak in 2018, causing many deaths. Based on current trends of measles vaccination coverage and incidence, WHO's strategic advisory group of experts on immunization concluded that measles elimination is greatly under threat and disease has researched in a number of countries that had achieved or were close to achieving elimination. WHO continues to strengthen the global laboratory network to ensure timely diagnosis of measles and track internationally spread of the measles virus to allow more coordinated country approach in targeting vaccination activities and reduce measles deaths from this vaccine preventable disease. No, this is the recent advances. Hmm, The title of the article is Risk Factor for Mortality Among Admitted Children with Complication of Measles in Pakistan and Observation Study. The objective of this study is to identify the vaccination status and risk factor for mortality in children admitted with complication of measles. The methodology. The retrospective study was conducted at Children's Hospital, Pakistan Institute of Medical Sciences, Islamabad, Pakistan, and compromised data of children admitted with complication of measles between the year 2013 and 17. Information of vaccination history, complication of measles, and anthropometry, hospital stay, and outcome within 15 days of admission were retrieved from hospital record. The results of this study is of the 307 children admitted, 79 were aged less than 9 months and were excluded. Of the remaining 228 subjects, 109 were unvaccinated. Risk factors significantly associated with mortality were an unvaccinated state of measles vaccine, being stunted, and encephalitis in comparison with pneumonia. A total of 39 children died within 15 days of admission. The conclusion of this study is encephalitis, non-vaccination, and undernutrition was significantly associated with mortality in children with complication of measles. The other study is measles outbreak investigation in nomadic population of Nasirabad, Balochistan, Pakistan in February 2018. In 14 February 2018, the district health officer of Nasirabad reported 6 suspected measles cases from the nomadic population of Dera Murad Jamali. Nomadic population means the mobile population to the disease surveillance and response unit of Quetta and requested an investigation. A FELTP fellow was deputed by the Director General Health Services, Balochistan, to investigate the outbreak, evaluate risk factors, and recommended control measures. The methodology of the study is a purposive sampling technique was adopted and a case control study was planned and conducted. Case was defined as an acute onset of generalized maculopapular rash and fever with cough and coryza or conjunctivitis from 29 January to 20 February to 2018 in a resident of Dera Murad Jamali. Every case searches along with interviews were conducted through a semi-structured questionnaire. Demographic, socioeconomic, clinical, and epidemiological information were collected along with assessment of routine immunization. 5 blood samples were sent for serology. The results of this study is a total of 49 cases, including 5 deaths, were identified. Males are 61% were more affected. The median age was 3 years. The age group of 0 to 4 years was most affected. The median age group of controls were 4 years. Of the cases, 71% were unimmunized for any routine antigen, while 32% of controls were unimmunized. Pneumonia contributes to 42.8% and diarrhea 38.7% were the most common complications. All 5 samples were positive for measles for IgM. Significant statistical association was found between nomadic population having 0 routine doses of measles containing vaccine and developing measles. The conclusion of the study is nomadic populations with low immunization was a probable cause of outbreak, resulting in the rapid spread of measles amongst the susceptible individuals in the community. Laboratory tests confirmed the outbreak. As a control measure, measles sorry. As a control measure, measles mpox vaccination and 6 health education session was suggested and carried out. It was also recommended that proper outreach microplanning and regular pulse immunization should be adopted in future. Now the time for MCQs. First MCQ is a post-measles case, a post-measles rare complication characterized by mental deterioration leading to involuntary movement, paralysis, muscle rigidity, and coma, probably due to persistence of virus in the brain, is due to meningococcal meningitis, rubella, subacute sclerosing panencephalitis, and GV syndrome. What is the correct answer?
C. C.
Yes, is the correct option.
C.
C.
Yes, C is the correct option. Second MCQ is measles virus is transmitted through the airborne droplets and is one of the leading cause of respiratory infection mostly seen in children of the developing countries. Which of the following statement is not correct about the epidemiological features of measles? Options are more than one serotype of virus has been identified. Humans are the only reservoir. Infection confers lifelong immunity. Infection can be transmitted from mother to the fetus.
A. A.
Yes, A is not correct. Only one serotype of the measles has been identified so far. Third MCQ is if a child has received a dose of measles vaccine before the age of 12 months, choose the correct option. Then they need only one future further dose of measles given at the age of 15 months. The child needs to receive 2 further doses of measles vaccine given at 12 to 13 months and at the same time as the preschool boosters. The response to a dose given before 12 months may be suboptimal due to persistent maternal antibodies in the baby. This may increase the risk of an adverse reaction to and subsequent dose. It is worth checking for measles antibodies before deciding to give a further dose. Which is the correct option?
A.
Yes, A is
A.
the correct option.
A.
The second dose is given at the age of 15 months. Fourth MCQ is in 2000, measles were declared eliminated from United States. Measles elimination is declared if options are no reported case of measles in a defined region for 6 months, no reported case of measles in a defined population for 6 months, no reported case of measles in a defined region for 12 months in the presence of well-performing surveillance system, no reported case of measles in children less than 5 years of age in a defined region for 12 months. Which is the correct option?
C. C.
Yes, C is the correct
C.
option. Yes, C is the correct option. Measles is declared eliminated if no case of measles is reported for 12 months in a well-performing surveillance system. Fifth MCQ is a 3-year-old patient presented in OPD with complaints of fever, cough, sneezing, red eyes, and macular pepper rash on his body. It is a suspected case of measles. The first sign of measles infection is rather the fever, cough, cough-like spots, or macular pepper rash.
A. A. C.
D.
Yes, A is the fever is the correct option. The first sign that appears on the 10th day after the incubation period is the fever. The rash appears at the day 14. Sixth MCQ is a 3-year-old patient presented in OPD with complaints of fever, upper respiratory tract symptoms, and rash on his body. His mother gives history that he also developed this kind of illness 6 months ago, which was a laboratory confirmed case of measles. The immunization status of child is unknown. The child is having second attack of measles or subacute sclerosing panencephalitis as a complication of measles or some other disease or history is strongly suggestive of measles.
C.
C.
Yes, C is the correct option. Seventh MCQ is a 3-year-old patient presented on OPD with complaints of fever, cough, sneezing, red eyes, and macular pepper rash on his body. It is a suspected case of measles. To prevent disease outbreak, which public health measures should be taken? Whether the isolation child for 7 days after the onset of rash, or the isolation child beginning from the onset of symptoms till the symptoms subside, Or the immunization of child after the onset of rash, or the immunoglobulin should be administered after the onset of rash. Which is the correct option?
A.
B.
A.
Alpha.
Yes, A is the correct option. Uh, immunization is given 2 to 3 days after the rash, and immunoglobulins, if immunization cannot be given, then immunoglobulins are given on day 3 after the exposure. Eighth MCQ is a child with no immunization status has fever with rash. To exclude other differentials on the basis of rash, measles rash begins behind the ears and spread in 2 to 3 hours to face. Always begins with fever, starts appearing on trunk or rashes or macules. Which is the correct
B.
option?
A.
A.
Yes, A is the correct option, as the rash of the measles appears behind the ears and then they spread to the face, while rash appears after the fever, and the rashes are both of the macule and maculopapular in nature. Ninth MCQ is an infant born to a mother suffering from measles regarding the measles during pregnancy, which is true. Measles causes congenital abnormalities in fetus. No case reported for vertical transmission of measles from mother to fetus during birth, or can cause spontaneous abortion and premature delivery, or the fetus should be vaccinated with live attenuated vaccine.
C.
C.
Yes, C is the correct option, while others are not correct. 10th MCQ is on 14 February 2018. 16 suspected measles cases from the nomadic population of Dera Murad Jamali, Nasrabad, Balochistan was reported. The factors associated with the spread of measles are in temperate climates like Pakistan. Measles is a winter disease probably because people crowd together indoors. Second option is population density and movement do not affect epidemicity. High immunization still have a high chance of outbreak. Measles have no impact on severity on the nutrition status of child. Which is the
A.
correct?
A.
A.
Yes, A is the correct
A.
option. Yes, A is the correct option. Thank you very much.
Thank you very much, Dr. West. Very nice presentation as always, and especially the important findings that you have shown and also repeated in MCQ number 10 about the nomadic population. That is really wonderful. This is how the real situation help us to learn better. Another important point is that the WHO strategy of measles. Have you shown it? May I
Yes,
missed
ma'am.
it in your presentation?
Yes, ma'am.
Would you please go to that strategy?
These are the management WHO's strategy.
Okay. This is about the WHO response. I want to know more about the WHO strategy for controlling of measles because we know there are three important strategies that have been introduced by WHO. First is that we have to clean up, then to mop up, and then we have to follow up. And that is why we need supplemental activities. Once the measles vaccine has been given during EPI schedule still, we need supplementary activities and increased immunization of the children, especially school going children in schools and other places. And similarly, the nomadic population is one of the highest population that should be continuously followed up, and that is the part of strategy.
Yes, ma'am. This is another present in 2010. The World Health Assembly established three milestones towards the future eradication. These are the three milestones that I have presented.
Okay. It is increased routine coverage with the first dose of measles containing vaccine by more than 90% nationally and more than 80% in every district. Reduced estimated measles mortality by more than 95% from the 2000 estimate. Reduce and maintain annual measles incidence to less than 5 cases per million. Okay, that is about something about the percentages, how it should be decreased. I was talking about the strategy for how to decrease the measles by having certain strategies, and then comes the indicator, and it is more towards indicators because when there are certain values that has to be decreased by certain